I'm not really sure if you'll be able to finish on time because the subject is really fatty. And I remember one of my colleagues from adult cardiology, he calls adult congenital as كجلمود صخر حطه السيل من علي. So probably the complex is a كجلمودين probably. Not to go into the incidents as it was clearly mentioned by Dr. Saman, but what we see nowadays with the improvement actually in early diagnosis and improvement in the cardiac surgery and post-cardiac surgery care, now we are expecting to see 85 to 90% of the children with adult congenital heart disease surviving to adulthood. Previously, we were losing like 25 or 30% of them. And for the first time in the USA, the number of adults with congenital heart disease exceeds actually pediatrics with congenital heart disease. The easiest definition for heart failure basically is when the heart fails to meet the body's demand. Clinical features, I think the most important thing to mention here is that the NYHA classification does not really apply very well in this subset of patients, especially those with cyanotic heart disease, or I mean, especially those with cyanosis or the RV being the systemic ventricle. The usual substrate lesions that lead to heart failure in complex cyanotic heart disease are complex left heart obstructive lesions, CCTGA or LTGA, detransposition with mustard or Senning palliation. We don't do it actually anymore now, very, very rare, and we don't see them a lot. But the problem with these patients is that the morphologic right ventricle is the systemic ventricle. Of course, cetrology of flow we see a lot, and their main problem is the severe or free pulmonary regurg. Single ventricle and Fontan, as we all know. The causes, basically, when there is a rhythm disturbance or a pump failure or increased body demand, like pregnancy, increased preload, and increased afterload or infection. The pathogenetic underlying cause here is the cyanosis or pressure overload or volume overload, myocardial dysfunction, either secondary to the pump, like acutely, or because of the procedure itself, and of course arrhythmias. These are comorbid factors, has to be considered actually in adult patients. Investigation, I think the ECG echo and cardiac MR, they take the lead here, and they're very important. And we are seeing actually advancement in the cardiac CT MR, and it's now playing a major role in adults with congenital heart disease, because the echoes, they don't actually project very well in the adults, especially in the extra cardiac structures. So I'll go over these things. This is a 25 years old young man who actually is known to have tetralogy of Fallot, pulmonary atresia, MAPCAS, VSD, and disconnected PAs. He underwent, when he was a baby, underwent a BT shunt, and then went unifocalization with RV to PA conduit, and then with a VSD closure, and then redo RV to PA conduit, and then PA's stenting for a stenosis, and then he lost actually follow-up for a long time, and then he came to us in Saud al-Babtain Cardiac Center, and one time he visited the emerge with shortness of breath and borderline low blood pressure, and this is his ECG actually, which looks actually very bizarre, you know, and we found that this patient was receiving mega doses of aldactone. We didn't know why, but anyway, when we tested his potassium, it was 7. So all what we did actually, we controlled, thank you. All what we did, we controlled his potassium, and then that's what happened in the ECG. This is 17 years old young man who was diagnosed to have LTGA with coarctation of the aorta, and underwent underwent cork repair, and later on he actually underwent tricuspid valve replacement, mechanical. He was not compliant to medications. He came twice. This is the first time in AF with variable conduction, underwent DC shock and improved after that. And here also, when he actually presented with tachycardia. The role of MR, we know it very well, 3D, but now we're getting image-related hemodynamics now. As you can see here, we get flows, pressures, resistance. The lesions that I chose to cover is basically the tetralogy LTGA Fontan. And we'll stop for a minute here to describe the difference between the left morphologic and the right morphologic ventricle. As you can see here, the left ventricle is cylindrical in shape, and it has a thick muscles, special arrangement of the muscles, myofibrils, and it was set to pump blood against high pressure and high vascular resistance. While if you look at the right ventricle, it's hugging the LV, and it's a thin-walled, it's trigonal in shape, and and it was set actually to pump pressure, to pump blood to a low pressure circuit and low vascular resistance. So if you ask this RV to pump blood against high resistance or high pressure, like in LTGA or single ventricle, then this RV has to modify itself. Once it modifies itself, trying to get thicker, and then it will lose its shape, and then the annulus of the tricuspid valve also will change. The RV will not be able to pump very well, as well as the tricuspid valve will have significant regurgitation. We'll go over a few echoes actually. This is the same patient who presented to us. This is the tetralogy of fellow pulmonary atresia, and MAPCAS underwent palliation with unifocalization. His X-ray, as you can see, the X-ray, as you can see, significant cardiomegaly, and there is calcification of the RV to PA conduit here. This patient, as I said, presented very late, and as you can see, there is poor LV function, RV function, huge dilatation of the LA, significant mitral valve regurgitation. You see, huge right heart here, as you can see, paradoxical wall motion. Unfortunately, the only hope for this patient now is heart transplantation. This is a second patient, another patient with tetralogy of fellow with RV to PA conduit. Initially, this patient had bilateral PAs stenosis, so he underwent stenting, and then this is actually abolished. Now we are left with significant pulmonary valve regage. Look, see, it's a free PI, dilated conduit, dilated right heart. This is another subset of patient. This is a tetralogy of fellow with severe obstruction of the conduit, as you can see here. Barely blood crosses through, with a gradient reaches up to 80 millimeter mercury. This is the 17 years old young man with with LTGA, and as you can see again, significant cardiomegaly with pulmonary congestion, and this is the tricuspid valve here. This is his echo when he presented for the first time to us. You can see parallel great vessels here. You can see this is the morphologic right ventricle pumping blood to the systemic circulation. There is no residual obstruction in the arch, but there is significant tricuspid valve regurgitation with poor function, as you can see. So he underwent tricuspid valve replacement, mechanical valve, and actually he did improve, as you can see. But later on, he presented with AF, and we didn't know for how long, so he underwent TEE to rule out any thrombi, and then we DC shocked him, and look, significant improvement in the morphologic right ventricle, as you can see here, from all aspects. So the fontan, as Dr. Saman told you, it's a connection of the SVC and IVC to the pulmonaries. So now the blood goes passively to the lungs instead of needing a pump. Okay. This is a dwarf with RV hypoplasia, and he has a significant aortic regurg. You see, there is a flow reversal in the aorta here, as you can see. With significant impairment of his left ventricle, he actually was sent for aortic valve replacement. Now the coming two cases are a different subset of patients where the morphologic LV for the fontan is actually the systemic ventricle. Here the main problem, as you can see, is the mitral valve regurgitation, significant. To compare it with another patient, this one actually is asymptomatic. I just put it for comparison. Look, that's the morphologic LV functioning very well. There is only mild to moderate mitral valve regurgitation, but he was doing actually fairly well. This is a 16 years old young lady, complex actually, again, cyanotic heart disease. She was a dwarf with RV hypoplasia, pulmonary atresia, interrupted aortic arch, and she underwent repair for the interrupted aortic arch, and then ended up with a fontan. But if you look at the function here, function looks fine. Patent shunt or patent fontan shunt, and
2 minutes.
patent shunts. Okay. The only problem with this patient causing these symptoms is the bulboventricular foramen. So the LV has to pump through this hole to the aorta, which is on the other side. So treatment, it could be medical or antiarrhythmic, APS with ablation. The surgical treatment includes redo for conduit obstruction or inclusion of the hepatic connection after a Kawashima when the patient presents with cyanosis, or of course assist device or heart transplantation. This is an angio for a fontan. This is an interrupted IVC, and then this patient actually had inclusion of the hepatics. You can see the hepatics here actually going to the fontan. The interventions in the fontan includes, this patient actually, we did a stenting for the fenestration because the pressure was high. So not only we closed the fenestration, we could actually stent the fenestration. Collaterals are very important in fontans. So whether it's an arterial, like aorta to pulmonary, though it might increase the saturation a bit, but it will actually end up by increasing the pressure in the fontan and failure of the fontan. So it has to be coil occluded or it has to be occluded because it will act like a left-right shunt. And when it's a veno-venous, same thing. It will act like a right-left shunt and has to be occluded as it will cause a cyanosis. This patient, as you can see here, significant PA's obstruction, underwent bilateral stenting, and as you can see here, very elegant and picture for this patient. Of course, we can do valve implantation. This is a patient with obstruction, but mainly free PI, significant RV failure with dilatation. So he underwent Melody valve implantation. And as you can see here, there is no regurg anymore on this. So I'm waiting for the injection, yeah. Look here, there is nothing. See, all the blood goes forward. We'll bypass this. So finally, to conclude, now we're seeing actually more and more patients. And the adult congenital heart specialist has to be actually well versed in the morphology of the congenital heart disease, and the presentation, hemodynamics, and the clinical approach to them. And of course, this depends on a successful program employing a multidisciplinary team approach. Early recognition and intervention is a key. It's very important, and I cannot stress the time more than this. If you look at this, see? They waited, and then it's the minute 94, and There you go. If you don't treat your patient, you lose, and your patient will lose. Thank you.
هذه آخر مباراة.